right, welcome everyone for another installation of our IACH for Pharmacists webinars. We're really excited today for I think what is to be a very hot topic right now in the pharmacy world and transplant world in general, which is RSV vaccines and monoclonal antibody usage. And today we have with us Jana Sawyer, who's going to be presenting on this topic. She's a clinical pharmacy practitioner in stem cell transplant and cellular therapy at the Veterans Affairs Medical Center in Nashville, Tennessee. She's really exciting, in terms of the practice site. There's only a handful of Veterans Affairs medical centers in the country here in the US that actually offer stem cell transplant, one of which being here in Nashville. So we're really excited to have Jana here to share her experience and discuss kind of updates with RSV therapies. With that, you can take it away, Jana. Thank you.
Awesome. Thank you for the introduction, Katie, and thank you to IACH for Pharmacists for having me today. Okay, so in terms of disclosures, I do not have any financial or non-financial disclosures to make. And since I do work for the Department of the United States government, I just wanted to state that the presentation materials reflect my views and not those of the government. So for a bit of an outline, we will start with some introductory and background information, move on to a review of available vaccines, and then we'll follow that with a review of monoclonal antibodies, and then finish up with a summary and recommendations. So first, what is respiratory syncytial virus, or RSV? It is a respiratory pathogen that can cause disease in both children and adults. It is most commonly presenting as an upper respiratory tract infection, but can also, though less commonly, present as a lower respiratory tract infection, especially in children. It is a seasonal respiratory virus running from approximately October to May in the Northern Hemisphere, and then from March to September about in the Southern Hemisphere. Most children, estimated about 90%, are infected by the time they are 2 years of age. And it does have a very significant impact on the healthcare system, with the United States Centers for Disease Control and Prevention, or CDC, reporting that RSV is responsible for about 70,000 hospital admissions annually in children that are under the age of 5 in the United States only. And that equates to about 2 out of every 100 children or infants being hospitalized. And then the raw number is about double that for hospital admission for adults that are over the age of 60. To kind of further highlight how significant the burden is or can be, there was a publication by Savage and colleagues. They performed a systematic review and meta-analysis and reported their findings, which included, among other things, some statistics surrounding specifically the 2019 RSV season. And they included articles that reported rates of acute respiratory infection, hospitalization rates, and in-hospital fatality in adults that were 60 years of age or older from various industrialized countries, including the US, Canada, various European countries, Japan, and South Korea as well. And it included 5.2 million cases of acute respiratory tract infections caused by RSV, nearly 500,000 hospitalizations, of which about 7%, or 33,000 in terms of numbers, resulted in hospital or in a fatality and death. So RSV, the virus itself, is a linear single-stranded RNA virus from the Paramyxoviridae family and the pneumovirus genus, and encodes 11 proteins. The virus itself has 2 transmembrane glycoproteins that are involved in viral entry into the cells of the host. And these are the attachment protein, and that's indicated by letter G, or these kind of bluish purple proteins on the outer shell here. And then the fusion glycoproteins, which are the F, or the kind of gray proteins there. The G glycoproteins are involved in binding to the cell surface, and then the F glycoproteins are the ones that facilitate fusion to cell membranes. In terms of incubation period, it would be the time from initial exposure to the time of appearance of symptoms, and the average is between 2 and 8 days for RSV. Subsequently, the viral shedding period is a very similar period of time too, so 3 to 8 days for that. In terms of transmission, it's mainly transmitted by direct contact. The virus is stable on hard surfaces and hands for several hours, and then to a lesser extent via the droplet route. But as the virus can be aerosolized, but by just large droplets. There are many risk factors associated with the development of respiratory tract infections related to RSV, and they're slightly variable for adults versus children. But in adults, specifically older age really greater than 75 years of age, those with chronic organ disease, anything from asthma, interstitial lung disease, heart failure, diabetes with microvascular complications, or a combination of these comorbid conditions, as well as those that live in a communal living or like a nursing home would all increase a person's risk too. And notably for all the patients that we treat, an immunocompromised status, of course, is also a risk factor. These are similar in children, though being a premature infant and specifically infants with neuromuscular disorders also could be considered at a higher risk. Very classic kind of signs and symptoms of a lower respiratory tract infection, as well as upper respiratory tract infections, are listed here. So with the upper, we see the classic runny nose, cough, sore throat, sneezing, things like this. And then with lower, we see some more severe symptoms like a more productive cough, potentially airway obstruction, coughing up blood, respiratory failure, etc. The mainstay of treatment really is supportive care, and that could be including, but not limited to, interventions such as IV fluids, supplemental oxygen, and then potentially more invasive interventions like mechanical ventilation. In children, potentially treatment with ribavirin, immunoglobulins, or a monoclonal antibody could be indicated, though we'll dive a little deeper into the mAbs here in a bit, but one of them, palivizumab, has not really been studied for this indication in a randomized trial at least. There was an observational study that reported no benefit in really reducing rates of severe disease or mortality, and it was well tolerated, but we'll get into some of that a little bit later. In immunocompromised adults, again, possibly treatment with ribavirin, but this is a recommendation purely based on expert opinion, again, due to the lack of high quality supportive evidence. Another treatment option could be immunoglobulins, but again, there's many organizations and committees that recommend against this due to the lack of really clinically significant improvement in any kind of outcomes. Okay, due to the lack of really efficacious treatment options, prevention truly is key. Non-invasive practices could include things like proper and frequent hand hygiene, covering up coughs and sneezes, and then wearing masks, which during the widespread use of masking during the COVID-19 pandemic, it really did highlight the benefit of masking in preventing lots, but especially nosocomial transmission too of respiratory viruses, including RSV as well. And then more interventional options like vaccination and monoclonal antibodies are what we will kind of dive into a little bit deeper now, starting with vaccines. So Arexvy is a GSK product, a GlaxoSmithKline product, and it is an RSV prefusion F3 vaccine. It is a recombinant adjuvanted vaccine and is approved in the United States initially in 2023 for a couple of uses for adults that are 60 years of age or older, as well as adults that are 50 to 59 with a risk factor for developing lower respiratory tract infections caused by RSV. And Arexvy was studied in a phase 3 trial that was randomized, placebo-controlled, and it was conducted in 17 different countries across Asia, North America, Europe, etc. And the objective of this study was to determine the vaccine's efficacy in preventing RSV-related lower respiratory tract infections following one dose of the immunization, single dose. They measured this with a primary outcome of RSV-related RT-PCR, or reverse transcriptase polymerase chain reaction, confirmed RSV-related infections. And PCR really is the gold standard for detecting RSV and has a sensitivity somewhere between 85 and 100%. Patients in this study were randomized 1-to-1 to receive the vaccine or a saline placebo, and there were about 12,500 participants in each group. It's a good number of people. Investigators included adults that were considered medically stable who were 60 years of age or older, and excluded those that were immunocompromised, had poorly managed comorbidities, or had received a prior RSV vaccine. They had a median follow-up of about 7 months, and authors had determined that in that first RSV season following vaccination, Arexvy had just over 82% efficacy in preventing RSV-related infection and was even more effective, so 94% effective in preventing serious infection. Vaccination still offered some protection in preventing RSV in that second season after vaccination, but at a lower percent of about 56%. And then in terms of safety in this study, there were 3 reported cases of neuroinflammatory diseases in the vaccine group, 2 of which were acute disseminated encephalomyelitis, and then there was 1 case of Guillain-Barré syndrome, or GBS. Toxicities were otherwise as expected and included things like injection site reactions, muscle soreness, headaches, things like that. Overall, from this study, the authors, investigators concluded that 1 dose of the vaccine was adequate in preventing RSV-related infection in the population that was studied, and that the reported side effects were acceptable. They did look into, of course, other outcomes, but it wasn't powered to determine efficacy against things like hospitalization or the need for respiratory support or death either. The second vaccine that we'll talk about is Abrysvo, and this is a Pfizer product, and that was also initially approved in the US in 2023. It's a bivalent RSV prefusion F vaccine that's recombinant, but it is not adjuvanted like Arexvy is. It is approved by the US FDA for adults 60 years of age or older, as well as for pregnant individuals but who are between 32 and 36 weeks gestation. And a single dose is recommended for those who are pregnant during the RSV season, who are between the 32 and 36 weeks of gestation that haven't received a prior RSV vaccine. Okay, so Abrysvo was also studied in a phase 3 double-blinded, placebo-controlled international trial. And the primary endpoint of this study was similar in that it looked at the vaccine's efficacy in preventing PCR-confirmed lower respiratory tract infections caused by RSV. They went on to include that patients must have had at least 2 or more RSV symptoms that lasted longer than 1 day, and they had to have had their positive RSV test within 7 days of the onset of symptoms. They had very similar inclusion and exclusion criteria when compared to that of the Arexvy trial that we just discussed. And these participants were also randomized in a 1-to-1 fashion, and they had just over 17,000 participants in each of the groups, vaccine or placebo. The investigators determined that Abrysvo had about 67% efficacy in terms of preventing RSV-related infection with 2 or more symptoms, and then even more efficacious at 86% in terms of preventing RSV infection with 3 or more symptoms. The actual number of cases of infection were quite low, with 11 in the vaccine and then 33 in the placebo group for 2+ symptoms, and then even lower at 2 cases and 14 cases for vaccine and placebo, respectively, in the cohort with 3 or more symptoms. Efficacy rates were similar across subgroups as well in terms of those, or based on age as well as a patient's risk status. And then in terms of safety for Abrysvo, there were similar rates of adverse events a month post-vaccination, as well as similar rates of serious events in each group. Events that were serious and that were determined to be vaccine-related included a delayed allergic reaction that occurred 7 hours following the injection. There was a case of diplopia that was consistent with a Miller-Fisher syndrome, a subtype of Guillain-Barré. And then there was a case of an MI, or a myocardial infarction, that was consistent with an acute inflammatory demyelinating polyradiculopathy type process that was also consistent with a Guillain-Barré type process. And then overall for the conclusion of this trial was that one dose of the Abrysvo did result in protection against RSV related infection and was successful in preventing it in those with three or more symptoms. Abrysvo is the only vaccine approved in the US for pregnant individuals, and that approval was based on this study, which was also a phase 3 study of very similar design, and it aimed to determine whether maternal vaccination was efficacious in reducing RSV-related lower respiratory tract infection in their newborns. And their primary endpoint here was rates of RSV-related disease at different pre-specified intervals following birth from a vaccinated mother. So pregnant women under the age of 50 were included if they were between 24 and 36 weeks pregnant with a single child, so no multiples, twins, triplets, things like that. And they were excluded if they had pregnancy-related complications, so eclampsia, a bleeding or clotting disorder, if they had a history of premature labor or prior stillbirth or things like that. And they also included those that had been or had received any type of immunosuppressive therapy within a year prior to the study. Participants here were randomized 1-to-1 to a vaccine or a placebo, and there were just over 3,500 individuals in each group. At 90 days after birth, there were 6 cases of severe disease and 24 cases of non-severe disease, which correlated to an efficacy of 57%. And then at 180 days after birth, there were 19 severe and 57 non-severe cases of an efficacy of about 51%. And then in terms of safety in this study, there were similar rates, again, of toxicities 1 month after vaccination. And they did note that there was a higher rate of preterm birth in the vaccine group, which was not found to be statistically significant, but potentially a red flag of sorts. And so a follow-up meta-analysis was performed, and they did not find any difference in preterm birth rates. They did not observe any serious vaccine-related toxicity events in this study. So overall, authors did conclude that the one dose of Abrysvo was successful in preventing RSV-related infection in infants at 90 and 180 days after birth following maternal vaccination. And then the third and final vaccine that we'll review is called mRESVIA. And it is an mRNA vaccine developed by Moderna and is approved in the US for adults 60 years of age or older. And it followed just closely behind Arexvy and Abrysvo and was approved in 2024. Its approval stemmed from this phase 2-3 trial that was international, randomized, double-blinded, placebo-controlled, and had a goal to determine efficacy in preventing, again, RSV-related lower respiratory tract infections with two or three or more symptoms. And then inclusion and exclusion were, again, very similar to the previous studies we've reviewed, always including notable exclusion of participants who are immunocompromised. Participants in this study were randomized 1-to-1, and nearly 18,000 received the vaccine, and then another close to 18,000 received placebo. mRESVIA had about 85% efficacy in preventing disease with 2 or more symptoms, and then 82% in preventing disease with 3 or more symptoms. And then authors also had looked at efficacy in preventing acute respiratory disease, slightly lower efficacy at 68% for that. And then safety-wise for mRESVIA, there were similar rates of serious vaccine-related events in each group, and the most common was infectious type process. At the time of the data cutoff, there were not any reported cases of Guillain-Barré syndrome. And then authors overall for this one had concluded that the single dose of mRESVIA was associated with lower rates of symptomatic disease and acute respiratory disease caused by RSV in this studied population. So there are many organizations that do put out recommendations surrounding vaccination, and I've included a few here from the US. And starting with ACOG, and that is the American College of Obstetricians and Gynecologists, they do endorse a single dose of Abrysvo for mothers who are between 32 and 36 weeks pregnant during the RSV season. And ACOG's recommendations come out each year. And so the current recommendations are for this season to vaccinate between September and January. They do include caveats, though, that the recipient must not be planned to deliver in the immediate 2 weeks following vaccination, and they could not have received a prior RSV vaccination. The American Society of Transplant and Cellular Therapy, or ASTCT, and the Transplant ID Special Interest Group, or SIG, have stated that they're unable to provide an evidence-based recommendation, again, due to immunocompromised patients being completely excluded from these trials, but they've encouraged to consider vaccination for those that are 60 years old or older if they're eligible for other routine vaccination post-transplant. They also have recommendations or recommend prevention for those that are around the patient, such as vaccinating eligible family members or caregivers or others. And then the third group is AKIP and CDC, AKIP standing for the Advisory Committee on Immunization Practices, and then CDC, again, the United States Centers for Disease Control and Prevention. And they support vaccination for everyone age 75 or older, and then for those 60 to 74 that have a risk factor. And again, those are things like chronic organ dysfunction, like cardiovascular disease, chronic lung disease, end-stage renal disease, diabetes with microvascular complications, residence in a nursing home, things like that. And they do not have any formal recommendations for vaccinating those who are aged 50 to 59. So now we'll move on to the monoclonal antibodies. So nirsevimab is the first one. It's also known brand name Beyfortus, and it is a monoclonal antibody, or mAb, that was developed by Sanofi that was approved in 2023 and has US FDA indications for infants that are born during or while entering their first RSV season, as well as for older children that are entering their second RSV season who are considered to be vulnerable to severe disease. So there were many trials that supported its approval and recommendations, and so I've selected 3, and we have kind of a comparison here of these 3 trials. So we'll kind of break it down here. The first one is the study from the nirsevimab study group, and it was published in 2020, and it was a randomized study of infants that were 12 months or younger that were born at 29 weeks gestation or later, during or immediately before an RSV season. The most notable exclusion criteria, which we're going to see is very, very similar among all 3 studies, would be prior receipt of an anti-RSV mAb, like palivizumab is the other one. They were excluded if the infant's mother had received Abrysvo vaccination during their pregnancy, and then if the infant was immunocompromised, among other criteria, like if they had a bleeding disorder, if they had been getting immune globulins, if they had an active infection, etc. So in this first study, there were nearly 1,000 infants that received a single intramuscular dose of the nirsevimab at the 50 milligram dose, and then about 500 infants received a placebo. The primary outcome was medically attended RSV-associated lower respiratory tract infections through 150 days after the vaccinate or after the injection. And they had defined medically attended as RSV infection that necessitated an emergency department or a clinic visit. There were 25 cases of RSV in the nirsevimab group and then 46 in the placebo group. And this equated to an efficacy of about 70%, which they found to be significant. And then in terms of safety, no hypersensitivity reactions and no serious treatment-related toxicities were noted either. There were more serious toxicities, grade 3 or higher in the placebo group compared to the treatment group, at least numerically. The overall takeaway from this first study was that the single dose of nirsevimab did offer protection against RSV-related infection in the healthy infants, and this even included some premature infants as well. The second is the MELODY trial, and this was published in 2022, and it was a phase 3 trial, randomized, blinded. They also included infants that were 12 months or younger that were born at 35 weeks gestation or later. They had, again, very, very similar exclusion to the very first trial. This one had also had about 1,000 infants receive nirsevimab at a weight-based dose, either 50 or 100 milligrams, and then another 500 infants received a placebo. And their primary outcome was medically attended RSV as well within 150 days, 12 cases of RSV in the treatment group and 25 in placebo, which equated to 75% efficacy, again, with statistical significance. Serious toxicities were numerically similar between groups, but investigators determined overall there were no serious treatment-related toxicities related to the nirsevimab. Overall, they did determine again that the single dose did offer protection in this group, which included term and some preterm infants, although not as preterm as the first study. And then the third study I've highlighted is the HARMONY study, and this was published last year, 2023. And it was a phase 3B open label randomized trial of infants that were, again, 12 months or younger who were born at 29 weeks or later, and then born again during or right before an RSV season in various countries in Europe. Notable exclusion, again, is very similar to the previous two trials. The dosing pattern for this study did mirror that of the MELODY trial with a 50 or 100 milligram weight-based dose. And they had many, many patients in this group. So the had 4,000, just about 4,000 in each the treatment or standard of care arm. Their primary outcome was hospitalization for RSV-associated infection. And there were 11 hospitalizations in the treatment arm and 60 in the standard of care arm. And this was an efficacy of about 83% in terms of preventing hospitalization. And this did reach significance as well. They did have low rates of serious side effects with some rare hypersensitivity reactions, but no serious toxicities that were determined to be treatment related. So investigators of this third trial did conclude that nirsevimab did offer infants protection against hospitalization for RSV. So palivizumab is another RSV protein pre and post fusion inhibitor that was initially approved in the US long time ago in 1998. It has a lower neutralizing activity when compared to that of nirsevimab, and for that reason is not really used routinely anymore. It also logistically is a bit more challenging to administer. It requires 5 once monthly injections compared to nirsevimab's just single dose kind of schema. And then palivizumab's FDA labeled indications are listed here, and that includes children who have a premature birth and are 6 months of age or younger at the beginning of their RSV season, if they've got bronchopulmonary dysplasia that required medical treatment within this time frame, and they're less than 2 years old, and infants who are hemodynamically or have hemodynamically significant congenital heart disease, again, 2 years or 24 months young or younger at the beginning of the RSV season. There are currently no formal recommendations for anti-RSV monoclonal antibodies in adults for treatment nor for prevention, but there's some ongoing study looking at safety and efficacy in adults. So in terms of monoclonal antibodies, major guideline and professional kind of society recommendations come from the group here, the American Academy of Physicians, or AAP, along with AKIP and CDC in the US. And they do recommend a single dose of nirsevimab for infants who are less than 8 months old and are born during or entering an RSV season. And they recommend administering within 1 week of life or just prior to the start of the RSV season, whichever is later. They also recommend a dose for those who are a bit older, so aged between 8 and 19 months, who are entering then their second RSV season, who are at an increased risk. And increased risk could be patients who are immunocompromised. It could be those with lung disease, cystic fibrosis, things like that. MAB administration is not recommended for children who were born to a mother who received the Abrysvo, the maternal RSV vaccine. And then due to the higher neutralizing activity, again, nirsevimab is what's preferred over palivizumab, though palivizumab may be administered if nirsevimab is unavailable. And if nirsevimab then becomes available and the infant is receiving palivizumab and has not yet received the total of 5 doses, then the recommendation is to then give a dose of nirsevimab instead. So in terms of a summary or recommendations, kind of to wrap things up, RSV vaccination is recommended in general for all adults 75 years of age or older, and for those that are 60 years of age or older who have a risk factor. A single dose of nirsevimab should be considered for infants born or during or entering their first RSV season, and then for those entering their second RSV season if they are at a high risk. And for transplant patients specifically, RSV vaccination maybe should be considered post-stem cell transplant for anyone who is of 60 years of age or older, who is eligible for their regular routine post-transplant vaccination series. And there's currently a lack of data, at least in a transplant or immunocompromised specific population, to support monoclonal antibody use. We may vaccinate those who are younger than 60, though, given that there's likely a benefit in the younger immunocompromised population as well. But again, not a wonderful wealth of knowledge on this topic yet. In general, the choice of which vaccination or which monoclonal antibody to use may be dependent upon availability. And sorry about that. In terms of booster doses, they are not currently being recommended, but they are being investigated, and so that may change in the future as well. If all vaccines are available, there may be a benefit for using the adjuvanted vaccine, or XV, in our immunocompromised population, given that they tend to have a worse response in terms of mounting a proper immunologic or proper response to vaccination, and the adjuvanted vaccines are a bit more immunogenic. Okay, well, this does conclude my presentation. I want to thank Katie again and IACH for Pharmacists for having me, and thank you for everyone who is attending. And now I'd be happy to take any questions that anyone might have.
Awesome. Thank you so much, Jana, for that really great presentation. Definitely encourage anybody to submit any questions they have in the Q&A section so we can address. But in the meantime, one question I have is, especially given the population that you're working with at the VA with a lot of, heavily kind of government funded insurance and things of that nature, can you talk about some of the challenges you faced with vaccine coverage and how you're getting these approved for patients to be able to give?
Absolutely. Yeah, it is definitely a unique practice area that I'm in here with kind of a government type health system, which is different from a lot of definitely community medical centers here. So we're lucky to have really fantastic follow up. So our patients typically leave our center, our allo patients, around day 100, and they return back to their home facility, which most of the time is not geographically near us. But we are able to follow patients really closely. Our medical records, electronic medical records, are integrated very well. So we have some wonderful follow up, or we can at least coordinate to follow up with uh, providers back home to continue care. We send everyone with a vaccine kind of schedule following transplant that we encourage their home providers to use as well. And we thankfully haven't had too much of an issue in terms of acquiring vaccines or getting things approved for our patients when the recommendations come from the transplant center. So I would say we are very, very lucky in that regard.
Yeah, I think it's a great example. And I'm sure, kind of correlates a little bit more with like our European colleagues who are probably listening in and kind of what their structure is like as well. So that's great to hear. And then what do you think kind of is the future? What do you think would be best practices in terms of using these vaccines in patients in different populations than what they're currently approved? So in like younger populations, for example.
Yeah, so we have been recommending vaccination post-transplant for patients as long as they're eligible for all their post-transplant vaccines. Um, Definitely for those 60 of age or 60 years of age or older, but to consider it in a younger population too. So I think as time goes on, I think that is the direction that we'll be moving. Is that we'll hopefully see more support for a younger population. I mean, we have a RexV approved for those 50 to 59. Again, not specifically in our immunocompromised patient population, but if we could really pick and choose how we design a trial, that would be wonderful. But we have to work with what we have. So I think the direction it's moving is going to be for younger people. It's going to hopefully be for immunocompromised individuals, and then monoclonal antibodies too. There's some different reports out there about some use in transplant patients. Palivizumab, the older of the mAbs, I believe they looked at giving our palivizumab prophylactically to 16 or so patients who were post allo transplant, given that there was an RSV outbreak in the hospital that they were being treated at, and no patients developed an RSV infection. So again, not a randomized trial, totally just retrospective kind of looking at those numbers. But hopefully we get more and more data, and kind of who knows what the future may hold for the mAbs as well.
Yeah, definitely. And I think either way, it's really exciting to finally see some of these therapies coming to market. And I know, at least in our
Yeah,
practice too, there's been a lot of interest about being able to use some of these agents in like cellular therapy recipients too. Since
absolutely.
we've definitely seen a lot of problems with RSV in that population as well. So hopefully we'll be able to start using those things more
Absolutely.
regularly in some of
Mhm.
these patients, even if they're not over the age of 50 or 60. So
Right. It really seems like we're really just at the beginning of all of
yeah.
this. So who knows what this kind of presentation would look like in a year or couple of years from now.
Yeah. Absolutely. Great. Well, I think that's all the questions we have.
Awesome.
Thank you again so much for a fantastic presentation, and we really appreciate you taking the time to be with us today.
Not a problem. Thank you again for having me. And thank you to everyone for attending.
Yep. All right. Thanks all. Bye.
Thank you. Goodbye.